Morning, everybody, or afternoon for other parts of the country. I'm Sean Warren, and this is my culminating presentation after 4 years of the program. And I'm really excited to share my learnings from the practicum experience, as well as some learnings from the past 4 years with you. I'm, like I said earlier, from Hamilton, Ontario, which is on the lands of the Erie Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. So my placement was at the London Health Sciences Centre here in London, Ontario, which is one of Canada's largest acute care hospitals, having two sites as well as a children's hospital. Through the course of the placement, I was in the project management office, which was a really great perspective because it's a centralized project management resource for the entire corporation of LHSC. That means that any project that's approved from the executive leadership team is assigned a project manager to help the clinical and organizational leaders progress through the steps of implementation. So I was responsible for project management as well as some of the sustainability planning through the course of my placement. I covered a lot of ground being in this office. We looked at some evidence-based methods for improving cancer treatment as well as emergency department efficiency. And I also provided some education with the team and other teams in the hospital around evidence-based practices, as that's one of the goals of the organization is to improve their adherence to evidence-based practices over the long term. The main focus of my practice, though, was the Substance Use Intervention for Adolescents program, which is a hospital-based substance use intervention for youth aged 12 to 18. There's not a lot of programs that offer this within Ontario. There's one comparable within Ottawa, but at the time of us doing this, we could only find that, and it was far more intensive than what we were looking to do in London. This is a critical resource because in Canada, about 1 in 4 youth displays some semblance of a high-risk substance use pattern, and that's exacerbated for other marginalized communities such as Indigenous folks. This is really important for London because London's surrounded by 3 Indigenous communities and serves a lot of Northern Indigenous communities as well through specialized services. And in Ontario, we see substance use rates for opioids, cannabis, alcohol, nicotine, and most classes of substances that far exceed national averages. The timing of this placement was also interesting because London Health Sciences Centre is in the middle of supervisorship, so it means that the hospital is being directly overseen by the province of Ontario. So there's a lot of restructuring that was happening, making it a bit of a build the plane as we fly it exercise because the organization was restructuring actively as we were implementing this project. So SNAP, as I mentioned, is for 12 to 18 years old. What makes it novel is that it's for folks that are accessing the hospitals, not just emergency department, but also their inpatient and outpatient programs. This grows on their existing adolescent or adult addictions medicine consultation service, rather, which serves 18 plus and is only available for folks within the inpatient units. The team felt it was really important to support folks the moment that they get through the door, as well as if they have follow-up in the community. This is provided through a hospital community partnership. So CMHA, Canadian Mental Health Association, is providing a nurse practitioner as well as an addiction counselor. And then the local harm reduction organization, even through the midst of upheaval, is providing a peer navigator role to this project. The goal of that is to improve the accessibility of the program because as we know, it's not just about having the service available, having the right people available is going to be important for youth to access this service. This service also supports with the 4-pillar approach to substance use. It provides prevention resources because brief interventions such as motivational interviewing is shown to decrease substance use later in life with adolescents, as well as decrease potentially riskier substance use. It provides connection to treatment resources as well as substance use education from a harm reduction framework. My role in SNAP was to provide guidance on evidence-based care modalities. So looking at the evidence and understanding what is possible within a brief intervention that's going to be effective for the clients and effective for the community specifically. I also provided a lot of guidance on community advisory methodologies. This program was put together very, very quickly, so there wasn't the opportunity to consult the community in the granting application. But one of the things that we did was we referenced back some work that I actually supported with a few years ago, which provided a facilitation guide on what it's like to engage with, in a trauma-informed manner, folks who use substances in London and surrounding communities, as well as substance use matter experts. So I was able to help put together some facilitation guides, which can be carried forward with the staff. I also got to analyze the program as a whole and provide some recommendations for some structural changes, as well as opportunities for growth and further robust planning within their processes. And this was done through the REAIM framework. And my colleagues earlier did such a great job of describing REAIM that I thought I wouldn't go through it once again. But here are the six recommendations that came out of our literature search, which was both formal literature as well as gray literature and internal documents. And that was part of the work that we did over the past several months, was trying to understand what does evidence mean when we're talking about serving marginalized communities, recognizing that their needs may not be well reflected within peer-reviewed literature, whether that's international or local. So we went with community advisory methodologies. We went with some of the work that was done previously to provide recommendations to the organization through the voice of folks with lived living experience, really trying to live that ethos of nothing about us without us, which we hear quite often when it comes to the area of substance use health. We have some themes. So one was around data, because there's no local data when it comes to youth ages 12 to 18 and the needs related to substance use. This is true within the hospital as well. There's great differences within the data utilization within LHSC, and this is mostly just based out of practicality. If a service is onboarded or if there's a need identified, the data tools are then updated to help make sure that that data is robust to support the implementation, planning, and evaluation. That hasn't been done for folks ages 12 to 18 accessing the hospital. We also provided recommendations around partnership. Again, the communities of folks that will be accessing these services were not engaged in the planning and have not been engaged in the implementation process to date. So how do we go back and make sure that we're engaging early and in a meaningful manner to make sure that this program is built with the needs of those folks in mind? The project had a bunch of milestones while we were there. We did a lot of work of defining the scope of the program, and this is a really good insight into what it's like working within such a large organization. It's quite a challenge to be able to change the scope of a program when you have to report up to an executive leadership team, back down to a clinical team, and then over to a funder. This process has taken over a year, and we were actually able to bite off quite a bit of this work while I was there over the past several months to make sure that the program is within scope, appeals to the needs of the granting organization, but ultimately is supportive of the community of folks that we're trying to serve through this work. We're able to create referral pathways, which we felt built on the work of previous community engagements, talking about self-referral pathways. How can youth engage with folks that they trust to access the care that they need? Sometimes it's not enough to be able to identify a need to a nurse or a physician at your bedside. Sometimes being able to talk to a peer or reach out on your own is an effective methodology. So we wanted to make sure that accessibility was at the core of what we were planning. We also did a lot of work around communication. Because this is a new program, we needed to communicate to all sorts of levels within the organization as well as within the community. So we were talking to executive leaders, project management teams, clinicians, and prospective clients, as well as funders. So this was a really robust communication strategy that touched on all sorts of different audiences and was a really great perspective on how to build this. Here's a bit of a graphic about where we were able to get to. And I think the years at the top of this graphic point to the challenges that have been faced by the program so far. When you're within an organization that is changing structurally, as well as trying to implement something so quickly without maybe doing the literature search and the evidence gathering before implementing, it can set you back quite a bit of time. And it's a very realistic view on things, because having worked in a number of programs, this is typically how things go, but this timeline was set back by a number of years. So we were able to work on the funding, the onboarding, and standards of practice guidelines and move things forward relatively quickly in the past quarter, with a mind to the fact that the past year has been really challenging to establish a scope, making up for some of the lost time with evidence gathering and community advisory work. Over the course of the placement, in the past 4 years, I was able to work on implementation and evaluation competencies. This was great because I was evaluating a program that was in the throes of implementation, as well as in the throes of implementation of a new organizational structure. And then I got to also, as I've mentioned earlier, hone some communication skills. Talking to executive leaders is not something that I'd say that I'm very good at. I like very pragmatic and very frank language, but being able to play to the politics, as our keynote addressed earlier, I think is something that I needed to grow. And this placement provided me tons of opportunity to grow that, as well as communicating with different stakeholders in the community who might want a seat at the table when it comes to advisory work, as this requires quite a bit of navigation. This placement provided me some really key insights. I think the power of community was a huge piece. London's fascinating because there's not a ton of service organizations within the city, but they've somehow built a very robust substance use health network there. It's not contingent on the practice of one person or the practice of a single organization to make sure that people in that community are cared for. When I was reaching out to let people know that the program was progressing and we were seeking input, everybody was excited, and it showed the amount of trust that these organizations already have with one another and the way that that trust can be mobilized to create quick change. Also, relational leadership, being able to relate to the folks that you're working with, build those relationships so that when things get hard, and they will get hard through the course of implementing a program, you're able to lean on one another and carry things forward with that trust. And then generating political will for equity. Equity was not built in to SNAP from the get-go. There's no distinct resources to serve the Indigenous communities around or within London through this work. And part of that is because of the funding opportunities that were accessed to provide funds for this program. And it takes a lot of work to try to create the will for equity, even if it's a financially prudent. Sometimes creating that will takes quite a bit more effort. I wanted to thank LHSC and Mia Siegel, my supervisor, for this placement, as well as Dr. Debar for the consultation and support, because it was a very eventful last several months for myself, professionally and personally. I want to thank all the colleagues that have been with me for the past 4 years, as well as the clients and communities that I've had the privilege of serving. It's my work now to try to repay all the learning and do well by all the learning that you've provided me over the past several years. So thanks very much for that trust. And if there's any questions, I'd be more than happy to answer.